Greetings. Let me first of all thank the American Tamil Medical Association for organizing this conference and for their kind invitation. These are my acknowledgements, and let us look at the scope of this problem, the problem of colorectal cancer and the burden of colorectal cancer in the United States in 2020. About 150,000 new cases are diagnosed every year, 18,000 under the age of 50. This is an important point to keep in mind because the guidelines have changed from starting the screening not at 50 but at 45. And it's important to keep in mind that 1 in 23 men and 1 in 25 women are at risk for colorectal cancer in their lifetime, and we lose 50,000 patients to cancer, colorectal cancer, every year. Unlike breast cancer, unlike prostate cancer, colorectal cancer offers a unique opportunity for us to prevent cancer, because we know that adenomas form in the colon, and after a lag time of several years, they change into cancer. If an adenoma or intramucosal cancer, that is stage 0 cancer, can be removed by colonoscopy with polypectomy, you prevent that patient from going to cancer and you prevent cancer-related death. Hence, colorectal cancer is ideally suited not only for screening but also prevention of cancer, as long as you intervene at the appropriate stage of the disease. Adenomas or intramucosal cancers, if you remove, you prevent cancer. When it comes to screening, which option should you go for? We have several different options that include colonoscopy, stool-based tests like FIT test and DNA test, flexible sigmoidoscopy, capsule colonoscopy, and CT colography. Among them, colonoscopy has several advantages. It can be used for screening, it can be used for surveillance, it can be used for diagnosis. And with this background, let us see a patient who comes to see you in the clinic. When you see a patient in the clinic, you should ask 3 questions to figure out where does this patient belong, whether the patient needs a diagnostic test, a surveillance test, or a screening test, high risk or low risk. So these questions include checking their symptoms, whether they have blood in the stool, anemia, or altered bowels, looking at their personal history, whether they have had colorectal cancer in the past, precancerous conditions like IBD for several years, or history of adenomas in the past. And finally, family history of either colorectal cancer or advanced adenomas. Advanced adenoma is an adenoma that is larger than 10 millimeters, has a villus component, or high-grade dysplasia. So once you have these things in mind, let's figure out. If the patient has symptoms, bleeding for rectum, anemia, etc., that patient should go for a diagnostic procedure, and you should be thinking about only one option, colonoscopy. On the other hand, if the patient has precancerous conditions, IBD for 8 years, or prior history of adenomas, or prior history of colorectal cancer, that patient needs surveillance exam, and again only one option to choose, that is colonoscopy. On the other hand, if the patient has no symptoms, no precancerous conditions, or prior colorectal cancer, then screening procedure, and the options depend upon whether there is family history or not. If they have a family history of colorectal cancer or adenomatous polyps, they belong to high risk screening group, and in that group the only option is colonoscopy. So when you have somebody who has no symptoms, no precancerous condition, and they belong to this high risk group, when do you start screening? If they have a first degree relative with colorectal cancer or advanced polyp below the age of 60, start screening at 40 or 10 years before the youngest affected relative, whichever is earlier. And following that, colonoscopy every 5 years. On the other hand, if they have 2 or more first degree relatives with colorectal cancer or advanced polyp, same advice. Screening at the age of 40 or 10 years earlier before the youngest affected relative, and interval colonoscopy every 5 years. If you have a patient with a first degree relative with colorectal cancer or an advanced polyp above the age of 60, then you start screening again at 40 or 10 years before the youngest affected relative. Then after that, your interval colonoscopy recommendation is every 10 years. Say for example, somebody comes and says, my aunt or my grandfather had a colorectal cancer or advanced polyp, that is a second degree relative. Then you screen at 45 and interval colonoscopy every 10 years. So first degree relatives at 40 or 10 years earlier, second degree relatives at age 45, and then every 10 years. So something to keep in mind. So first degree relatives 40, second degree relatives 45 to start. Something to keep in mind. So on the other hand, the patient has no symptoms, no precancerous conditions, and no family history of colorectal cancer or advanced adenomas. This patient belongs to that average risk group, and in this patient you have several options. You can go ahead with colonoscopy or any of these options. And if you have a patient and is reluctant to go for a screening, there are several different ways you can offer screening. You can risk stratify the patient, or you can offer sequentially. You give them colonoscopy. If they say no, then you go to the FIT test. If they say no, they can go to DNA based test. Or you can offer all the multiple tests and share the pros and cons and explain to them and let the patient take. And if you go to colonoscopy, that is one step approach. That is, you offer, it's done, you don't have to worry. On the other hand, if they do anything other than colonoscopy, it is a two-step approach. That means if the stool test comes positive, they have to go for colonoscopy. If CT echography comes positive, they have to go for colonoscopy. They have to understand that. And let us look at the benefits of different procedures, and especially colonoscopy. We have data from large studies, starting with the National Polyp Study, which has shown that colonoscopy reduces colorectal cancer incidence as well as mortality. And let us look at the so-called two-step approach, starting with the stool test followed by colonoscopy. When it comes to a stool test, we all have done this checking the hemoglobin, either with the fecal occult blood test, where you're checking the heme component by using peroxidase activity. And the problem with that is there is a dietary interference, and so patients have to be instructed about what to eat, what not to eat, and they have to give 3 samples for a good test. And important to keep in mind, heme coming anywhere from the GI tract can be detected in the stool. In contrast, the FIT test checks the globin portion of the hemoglobin, using an immunochemical test, and this doesn't require any dietary instructions, and only one sample will work. And unlike the FOBT test, FIT test only checks for colonic bleeding, as the globin gets broken down if it is coming from the upper GI tract. So some concepts to keep in mind. So let us look at the FOBT test. Many studies have shown that either biennial screening or annual screening has been shown to reduce both the incidence and mortality of colorectal cancer. And the same with the FIT test. Again, the FIT test has a sensitivity of 91%, specificity of 90%, but you have to keep in mind this is for colorectal cancer. For adenomas, they all fall below 50%. For serrated adenomas, they are below 20%. So you may not find polyps that are easy to remove when they are in early stage. The new kid on the block, that's been there for quite some time, that is using the multi-targeted stool DNA and hemoglobin test together. And what they have shown is it has a very good sensitivity for colorectal cancer, but the specificity is a little bit low. Again, even with the MTS DNA test, for advanced adenomas and serrated adenomas, again, less than 50%. So in an economic model, what they've shown is annual FIT test and every 10-year colonoscopy has been shown to be more effective and less costly than every 3-year multi-target stool DNA test. And it's also important to keep in mind that the DNA test specificity decreases with age. So if you have an elderly patient and you do this DNA test, you may be pushing them for a colonoscopy where they may not find anything. And the risks of colonoscopy need to be kept in mind. So if you do a DNA test is positive, you do a colonoscopy that is negative, should you be worrying about it? As long as the quality of colonoscopy is good. There's no need to do an EGD, there's no need to do a CT scan, there's no need to do a colonoscopy at a shorter interval for a positive DNA test followed by a negative high quality colonoscopy exam. A little bit about flexible sigmoidoscopy, again shown to be beneficial, but the use has declined, as most of us know. It has the same hassles that are required for colonoscopy, and it doesn't examine the entire colon. And it's uncomfortable when you do it without sedation and is not very effective in women. CT colography, again, although has been shown to be helpful, it is not as sensitive as colonoscopy, and it could miss right-sided lesions, flat lesions, and like colonoscopy, it is operator dependent. Again, the same applies for capsule colonoscopy. So let us put all these different tests together and look at the harms of screening. With stool-based test, there is a chance for false positive test that may lead to unnecessary colonoscopy and the harms of colonoscopy. For colonoscopy, the bleeding risk is 8 per 10,000, perforation risk is 4 per 10,000, splenic rupture occasionally or rarely, and older patients, preparation-related complications, anesthesia-related events, especially aspiration pneumonia, and a risk of missing cancer, that is post-colonoscopy interval cancer, of 1 in 3,000 procedures. For CT colography, radiation exposure, although fast scans reduce that risk, and extra colonic findings might require additional testing and costs involved. For capsule and endoscopy, again, you cannot get away without the prep, so prep related issues and capsule retention. So let us talk about how often should we be doing these screenings. When you go for a fit test, it should be every year. Colonoscopy, every 10 years. And if you go with the multi-target stool DNA test, every 3 years. CT colography, every 5 years. Same with capsule colonoscopy and flexible sigmoidoscopy. So we have talked about different screening options, and now whom to screen. Until recently, we have screened patients between the age of 50 to 75. In the last 1 year, task force recommended to start screening at age 45. And that's because colorectal cancer incidence has been rising in young adults starting in the 1980s. Colon cancer and rectal cancer both have increased in incidence in the younger and decreased in the older. If you want to look at a little more about the problem, persons born around the 1990s compared to 1950s, 2 times risk for colon cancer, 4 times risk for rectal cancer. And the recommendations suggest that the task force recommends to screen starting at age 45, and if you do that instead of at 50, it would result in 25 more life years gained per 1,000 individuals screened. But you also have to keep in mind that starting at 45, and if you look at how many people are there in the United States between the age of 45 to 49, that is 21 million individuals that will be coming into the screening program. In your practice, keep in mind when somebody reaches 45 to talk about colorectal cancer screening. So let us look at screening uptake in the country. It is 60%, although some states have done very well, other states have not done well, but 40% not yet fully screened. And then this additional 21 million, and that's going to be a problem that we need to address. Let us discuss about what to do in terms of screening elderly who's 75 plus. In order to understand this, you have to appreciate the survival benefit. How much time does it take to have a survival benefit of colorectal cancer screening? It takes about 10 years to prevent 1 death for every 1,000 patients screened. So keep this thing in mind. 10 years to prevent 1 death for every 1,000 patients screened. And this has to be weighed against the risks. As we age, our comorbid illnesses increase the mortality risk. The procedure associated complication risks need to be kept in mind. And also, against this risk, you have to keep that benefit of polypectomy, because there is a 7 to 10 year delay. So how do you decide whether to screen that 77-year-old? You need to keep in mind whether they have multiple comorbid factors and patient's preference. Patients with cardiovascular disease and multiple comorbid conditions do not benefit, especially those with hypertension, diabetes, hyperlipidemia, and cardiovascular disease. And that is something to keep in mind, and at the end of the day, it is a discussion that will help you and your patient to make a joint decision. Next comes is you decided to send the patient for colonoscopy. and where should you send that patient. And this has been an area of where we have learned a lot in the last 10 years. And one concept that I want to share with you is adenoma detection rate, and the other concept is post-colonoscopy interval cancer. So post-colonoscopy interval cancer is you perform a colonoscopy, and then 6 months to 3 years down the road, within that time frame, if the patient develops cancer despite having had a colonoscopy, that is post-colonoscopy interval cancer. That is directly related to the quality of that exam. And how do you assess the quality of the exam? Although there are several different ways, one important aspect is, our pointer is adenoma detection rate. Let me explain this concept of adenoma detection rate. So say for example, you send 100 of your average risk patients to an endoscopist for screening, and that endoscopist finds adenomas in 10 patients, and that endoscopist's adenoma detection rate is 10. So 10 patients out of 100 average risk screening patients. That's the way it is defined. And what is adenoma detection rate to do with post-colonoscopy interval cancer? This is thanks to Doug Coley from Kaiser Permanente, where they looked at their huge patient population and endoscopists who have taken care of them, and divided them into different groups based on their adenoma detection rate. And the lowest adenoma detection rate in the 10 to 15 range, and the highest is 40 plus range, into several different groups. And then they looked at how many of the patients developed interval cancer if patients went to a particular endoscopist with a adenoma detection rate of, say, for example, 13. About 10 colorectal cancers develop per 10,000 patient years. As the adenoma detection rate increases, the colorectal cancer decreases. As you can see here, I've averaged the quintile ranges to make it easy for us. And as you can see here, as the adenoma detection rate comes to 43 compared to when it was 13, it dropped from almost 10 to 5. So the summary of this work is, for every 1% increase in adenoma detection rate, there is a 3% reduction in colorectal cancer development and a 5% reduction in colorectal cancer mortality. Hence, colonoscopy and colorectal cancer screening is operator dependent. And how do you judge that operator besides the adenoma detection rate? So there are three important parameters that you should be looking at when you see your patients back in your clinic after having had a colonoscopy. Did the endoscopist reach the cecum? So is that endoscopist having a cecal intubation rate of 95% or more? If not, then that endoscopist is likely to have more interval cancers in his practice. So keep that in mind. Next, is the endoscopist taking enough time to examine the colon during the withdrawal phase from the cecum as the scope comes down? That is the withdrawal time. If they come faster, they're going to miss polyps and they're likely to have interval cancers. A minimum time is 6 to 10 minutes. Nowadays, the data shows 10 minutes gives a better protection than 6 minutes. The societies have come up with guidelines that an endoscopy should have an adenoma detection rate of 30% in men and 25% in women who are having average risk first-time colonoscopy. In our own practice at Anderson, we do get adenoma detection rate for every endoscopist and give them that result. And for those who are low, they're encouraged by education. Currently, our adenoma detection rate is in the 40 to 50% range. So important to keep these things in mind so that when you offer colon cancer screening for your patients, it's not just telling them to get screened, but make sure that they're getting good quality colonoscopy with high quality metrics. How about you see a patient who has had colon cancer or IBD or adenomas in the past? What should you do? If they have had a colon cancer, they should have a follow-up exam at 1 year. If they had an advanced adenoma in 3 years, advanced adenoma is more than 10 millimeters in size, or a polyp with villous features, or a polyp with high-grade dysplasia. If they have none of those advanced features, that is low-risk adenoma, between 5 to 10 years, depending upon the number of adenomas that they have. If the patient has IBD for 8 years, they should start their surveillance procedure. And in all these patients, the procedure of choice is colonoscopy. So let me summarize. As you think about your patients, consider family history and decide timing of colon cancer screening. It's also important to keep reviewing the family history. Somebody who has no family history down the road may develop a family history in a family member, and suddenly he jumps into the high risk group, and you have to change your game plan for that patient. That happened in my practice as well. Encourage patients to get screened and think about when they start at 45, because it takes time for people to think and decide about colonoscopy or one of the other screening modalities. Offer options for patients to choose and discuss the pros and cons, and make patient comfortable with his decision. And set up a system whereby the positive stool tests are followed up with a colonoscopy. And it's very important not to lose track of those positive stool tests. When it comes to colonoscopy, encourage your patients to do the colon prep right. Without that, we cannot examine the colon well. We will miss polyps. And check the endoscopist quality metrics: cecal intubation rate, withdrawal time, adenoma detection rate. And adenoma detection rate determines the final outcome, whether somebody is going to develop interval cancer or not. For the most part, we do very well, but I think this summary would help you in your practice. I'm grateful for your time. I really appreciate it. Thank you so much.